live.
Good afternoon, everybody. Matt Kearney here. Starting with apologies. Technical gremlins, and I cannot get my camera to work. It's the second laptop I've tried. The first one, the sound was rubbish. And we decided absent face was probably better. But you can't see me and I can't see you, but I hope that you're all there and that you enjoy the session we're going to have today, when we're going to talk about the Powering the Prevention Shift, the CVDACTION Impact model. And I'm joined by Laura Boyd, who's going to do a lot of the background work and managing questions, and also by Jack Mallender from Economics by Design and Jack Cattle from Get the Data, who've built the health economic model. You will see the Q&A button, so please put your questions there. There isn't a facility to ask live questions, but if you put questions in there as we're talking, we're going to give you a bit of an intro, then take you through the report and the headlines, and Jack's going to give a demonstration of the model, what you can find when you go there, and then we'll have a Q&A session. So to start with an intro, so my name is Matt Kearney. I'm a GP clinically and leading the CVDACTION work. I was the National Clinical Director for CVD Prevention and led development of CVD Prevent, the national audit, and CVDACTION is very much building on that with the objective of making data as actionable as possible. So we all know that cardiovascular disease is important, and we know the impact it has and the cost for us, for individuals and for the health economy and the wider economy. And quite rightly, this is now the national mission for England to reduce deaths from heart disease and stroke by a quarter in 10 years. So it's a huge ambition, but a justifiable ambition. What we know about cardiovascular disease is that it's highly preventable, both through supporting behaviour change, but then treating these high impact risk factors. That is our bread and butter in general practice, and loosely known now as secondary prevention. And there are various definitions of that, historical definitions, but from a pragmatic perspective, I think the stuff we do in general practice to manage these high-risk conditions comes under that secondary prevention umbrella. And it's important to acknowledge that because it's difficult. We have a great ambitious mission and we have a big challenge around secondary prevention. So under-treatment, late diagnosis and under-treatment of the high-risk conditions that cause CVD is entrenched and long-standing and has changed very little in decades, despite NICE and QOF and CQC and all the other levers that we've thrown at the problem. So much so that 1 in 3 people with diagnosed high blood pressure are not treated to target. 1 in 3 is an astonishing number. 1 in 6 people with cardiovascular disease are on no lipid-lowering therapy, essential life-saving treatment for those patients. And we see the same enormous levels of under-treatment with CKD and diabetes. And the result of this, we know, is that thousands of people have avoidable heart attacks and strokes every year. So that's the problem. It is a substantial challenge. And if we don't solve it, we're not going to deliver the national mission for CVD prevention. And this was very much faced head on in the 10-year health plan and articulated really clearly to me a couple of days ago at the launch of a report in the House of Commons on cardiovascular disease prevention, and voiced by a woman called Annika, who is now on hemodialysis for her kidney failure, and for which the most likely cause is hypertension, that remained undiagnosed and untreated for years until she turned up with already quite severe kidney failure. And a powerful story, but the problem is it's a common story, and we know under-treatment is widespread. But if we're going to come up with solutions, we have to unpick why this is difficult to do in real-world general practice. And it's because these conditions are often asymptomatic. People don't know, have no warning signs that they need treatment. We have huge time pressures, capacity pressures, as everybody knows in primary care. The pathways that we've constructed to deliver QOF are very reactive. They don't encourage or reward proactive management. And we do not look for patients who we're managing but are undertreated. It's not in our processes, in our DNA. And if we don't look, of course, we don't see. So we don't know that all those patients are undertreated. And we have lots of data tools, and some of them wonderful, do offer fantastic functionality and are great support to our work in many, many ways. But none of them address the real world challenge, is that we don't have the capacity or the ways of working to act on the data, except in a very piecemeal way, or it relies on the individual clinician to have the time and space to take action. So this is the problem that have tried to unpick and are trying to address through CVD Action by targeting the how, not just providing information on what we need to do and the guidance, but actually how do you do it in the real world. And we've identified these three critical pillars that are part of the CVD Action programme. One, that we make data really easy to use by finding every single patient on our lists with cardiorenal metabolic conditions who are not on NICE recommended treatment, but then making it very easy to work on that data. But data alone is not enough. And so the programme offers teams structured support to change their ways of working so that they can optimise at scale. But the third element, equally important, is to work with teams with shared step change objectives and a relentless focus on, are we delivering those objectives as each month goes by? And you see the conditions there on the right that reflect CVD Prevent, and we're currently building in heart failure and obesity. We, with some funding from NHS England in London, we ran a demonstrator programme across 10 PCNs, 600,000 population, and there's a link there to the UCL partners evaluation of the programme. The bottom line was that it was very successful. Firstly, because it was really embraced by primary care colleagues, very much taken on, local leadership applied to it, lots of innovation around leadership, particularly innovation around health inequalities. And a common comment from GPs in particular was, what we like about this is it's not a new ask, it's a way of doing the day job differently and more effectively and creating capacity. But you see the numbers there on the right. This is just a snapshot, but these are step change numbers in a relatively small population in a short time frame. 1,700 patients newly treated to target, 400 plus patients with cardiovascular disease newly started on statins. And you can measure how many heart attacks and strokes that will prevent in a short time frame. So having done the demonstrator programme, we'd answered the question, well, if you change your ways of working, will it deliver step change? And the answer is yes. But the next question was, well, if we do this at scale, if we make this standard practice, to routinely look for and optimise patients who are undertreated, what will be the impact? And this is where we worked with and commissioned Jack and Jack to build this health economic model to answer that question. So I'm going to hand over now to Jack and to Jack.
Thank you very much, Matt. And hopefully you can see me. My video is on. My name's Jack Smallender. I'm a health economist, and we were delighted to be asked by CVD Action to look at the potential economic value of this approach. And so we undertook some modelling and focused very much on comparing the costs of investing in this technology to identify and support patients with the economic benefits to the health and social care system and the wider economy. And our starting point was that all of the clinical interventions that we were going to model would happen if the people were correctly identified, were already recommended by NICE as providing high value to the NHS. So they are backed up by their own economic models, they're backed up by their own clinical practice guidelines. That takes together the clinical effectiveness of those medications in terms of improved health outcomes, as well as the economic evidence that is needed to support NICE recommendations. Our analysis used established economic modelling techniques and is throughout compliant with the guidelines that come from the Treasury Green Book. Now, the focus of the analysis was to look at the impact of modelling the optimisation of medical management for hypertension, high cholesterol, diabetes, and chronic kidney disease. What we didn't do was look at the potential impact of wider lifestyle and behavioural interventions. So that might be improvements in things like physical activity or diet. We focused solely on the impact of medication management. And we looked at 4 high-impact treatments across those conditions. So blood pressure lowering therapy, cholesterol lowering therapy, RAA, renin-angiotensin aldosterone. I get this my tongue always gets tired trying to pronounce these system inhibitors, and sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. As I said, just to reinforce, we did exclude the potential impact of wider lifestyle and behavioural interventions. And in fact, what we did, bringing those 2 together, we looked at 12 cohorts. So for hypertension, we looked at individuals diagnosed with hypertension, but whose blood pressure was not treated to target. With cholesterol, we looked at those individuals with CVD who were not on lipid-lowering therapy. We looked at those with CVD, but on suboptimal dose or intensity of statins, and individuals with CVD, but were already on the maximum statin therapy, but not necessarily treated to target. And then for those with chronic kidney disease, we focused on the individuals that were indicated for RAA therapy, but hadn't been prescribed, those that were indicated for SGLT2I, but not prescribed, and those with CKD and CVD, not on LLT. And then finally, those individuals with CKD and hypertension that were not treated to target. And then finally, we did pretty much the same thing for diabetes. So the patients were indicated but not prescribed for RAA or SGLT2I, and then patients with diabetes and hypertension but not treated to target, and then finally patients with diabetes and CVD but not on lipid-lowering therapy. So those were the 12 cohorts we looked at in our analysis. Now, what we did was we focused on what the intervention would be, which would be identification and then optimizing medications management. And we looked at the health benefits that would be achieved. And we looked at that specifically by looking at the reduction in the likelihood of these individuals experiencing an adverse health event. And the events we included were myocardial infarction, ischemic stroke, heart failure admissions, and progression to end-stage kidney disease. And then in terms of actually modelling this through, in terms of the impact of those interventions, we used a methodology that economists often use, which is a sort of probabilistic model which follows a pathway for patients. And we used a discrete time cohort-based Markov model that simulated the disease progression and event occurrence over a 15-year time horizon with annual cycles. And the model itself simulates 10,000 individuals for each of the 12 cohorts I described across 1,000 Monte Carlo simulations. So it's really looking at that, the likelihood of individuals passing through these pathways and having one or more of these events, or even having life limiting through death. And then in terms of actually looking at the economic benefits, we again, as I say, we had the costs of the program, we had the medication cost, we had information about the number of these events that are avoided, number of strokes avoided, for example, and we were able to use data to model the economic benefits that arise from avoiding those events. So we looked at the improved health system efficiency or productivity, so healthcare utilisation that would be avoided if those events were avoided. Where we were able to find evidence, we looked at the reduced need for social care, we looked at the reduced need for informal care, and we also looked at the increased likelihood of individuals participating in work and hence economic activity. What we didn't do for this study was to calculate QALYs or health utility outcomes, and we didn't try and estimate the value of a QALY or the societal value of health. So we literally focused solely on a sort of cost of illness approach, I guess, and looked at the benefits that way from the avoided events. And we translated the estimates that came from that modelling into present day values using discounted cash flows in line with the Treasury Green Book. Now, all of the data that we used was sourced from established high quality secondary sources. And all of the assumptions that we used within the model have been sourced from pre-published peer-reviewed literature. We haven't done any primary research to support this. And the analysis that we have done and the assumptions that we've used have been reviewed by an expert advisory group with expertise, particularly in CVD prevention and primary care. I wanted to just talk a little bit more about the sources, but it is all included in the report, which is published online. There are four sort of buckets of data that we used. The first is the change in the annual probability of event, including death. This is what we use for that Markov modelling, for those of you who are analysts and are interested. And we sourced all of those probabilities from a synthesis of peer-reviewed literature. And as I said earlier, those assumptions were reviewed by the expert group. For the population estimates of current treatment uptake for each of our patient cohort, we were able to provide estimates for each integrated care board, and they were sourced from a combination of data from the cardiovascular disease prevention audit and also from sample data provided by IQVIA, and also from the CVDACTION pilot data from North West London ICB. And we were able to estimate, therefore, what the current treatment uptake was for each of our 12 cohorts for each ICB. And then the cost estimates that we used in terms of the intervention itself. So this is the actual deployment of the dashboard and the support for the primary care physicians in implementing new pathways. That came from CVDACTION. It included the data tool license and structured support for the workforce and pathway transformation. And then we also included the costs of increased drug therapy. And then finally, the economic costs or benefits, if you like, of each of the health events came for each of the myocardial infarction, stroke, heart failure, and so on. These were all sourced from existing published cost of illness literature. So, for example, where a study had been done to look at the cost of a stroke, we were able to take data from that and use that for our economic benefit modelling for every stroke avoided. I wanted to say a little bit about the scenarios that we used in the modelling, because we were very keen to avoid, and this came from advice from the expert group, to avoid an assumption which said if everybody's medication was optimised, what would the results be? Rather, we wanted to see what would happen if we moved from where we are now to what we've called step change, which would be a significant but very manageable increase in optimization of their medications, to and also advanced, which would be if we really were ambitious about moving to optimization. It's probably unlikely we'd go beyond advanced in practice, because obviously you won't necessarily get everybody complying, or indeed it might not be the right treatment for individuals based on local clinical judgment. So we took as our baseline this step change. So if you look, for example, at this table, you can see that across England, blood pressure not treated to target, the current estimate is around 67%, and we assumed that we could get that up to 80%, which is not an unrealistic assumption. And you can see for some of these, the current compliance is very suboptimal. So for CKD, SGLT2I indicated but not prescribed, you can see that the current estimates of optimization are well down at 30%, and the step change would be quite a big change, would be taking that up to 75%. So what did we find in terms of events prevented? So the cumulative impact for our treatment cohort were in year one, across all of the events, we estimated that you would be able to, even in year one, avoid over 21,000 events across the country. By year five, that reaches over 99,000 events across the country. And you can see some big results here for strokes and heart failure admissions and heart attacks. These are very real health risks that are avoided by moving to this model. When we translate that into economic benefit, you can see here estimates of the value of those events avoided from the different perspectives of the health and care system, the social care avoided, the informal care avoided, and lost productivity avoided. And you can see here the cumulative impact by year five across all of those is over £5 billion in terms of economic benefit. And even just if we look at the health and healthcare costs avoided alone, these are very expensive events. So avoiding this type of number of events, we were expecting to see £1.7 billion worth of savings across this period. What was really interesting to us was the reduction in pressure on informal care, and this arises largely from the stroke events avoided. If we look at that in terms of the benefit to cost ratio, we can see then, if we take the perspective of health alone, that even within year one, for every £1 invested, you get £1 back. So if it washes its face, even from just a health system utilisation alone, within the first year. By year five, you're looking at a benefit to cost ratio of 1.8 to 1. So for every £1 invested, you get 1.8 back. Taking health and social care together, those figures go up. And I should say that not all of our cost of illness studies included social care costs, and we've been very conservative and excluded those. We haven't tried to sort of impute those numbers where they were missing. When we look at the wider economy, which includes informal care and people's ability to go back to work, the number is really quite staggering. So if we're looking at the wider health impact of doing this, we're talking about a return on investment to the UK economy of 5.3 to 1 by year five. Now, it is worth noting that these figures do not include the societal value of health. They do not include a QALY value of health. These are solely the impact on the health and care system, the social care system, the informal care system, or informal care, and wider productivity impact. So if we were looking at this from a nice perspective, just on the top line of health, this would be what we call a dominant intervention. In other words, you wouldn't need to calculate a cost per QALY, or you wouldn't be able to calculate a cost per QALY because it's net saving. Now, if we made our ambitions a little harder and we went for that advanced ambition, really did try and drive that medication compliance up, then these figures go up, as you might expect. The number of events avoided goes up from 99,000 to 164,000, 66% increase. And also the value of the economic benefits go up from 5 billion to 8.74 billion. So that would increase that benefit to cost ratio to 6.5 pounds for every £1 invested. And that's not assuming 100% compliance. That's just taking us to sort of a really ambitious compliance estimate. Now, obviously, it would be remiss of me not to reinforce that there are some limitations to this and precautions to this. So, you know, as with any economic modelling of health outcomes, there are lots of uncertainties. We've tried to take that into account through the Markov modelling approach. The other issue that we have is that we have different estimates of the size and prevalence of these conditions. We have overlaps between individuals who have multiple conditions, and we've had to make some fairly strong and simplifying assumptions, and also do quite a bit of calibration to make sure that we didn't end up overstating the impact of this. We've also had to make some really simplifying assumptions about adherence to medication, around side effects, contraindications, for those whose treatment is assumed to be optimized. And, you know, whilst we have made every effort to assure the quality of the source information from the literature, we validated these with experts. You know, the sources necessarily vary in terms of the context of the study that was undertaken and the setting in which it was undertaken and when it was undertaken. So, you know, we've done the very best we can with the state of the evidence as it is. We have therefore done lots of sensitivity analysis to sort of stress test where we might have overestimated or underestimated, and it didn't change the conclusions of the analysis to any significant extent. So in summary, CVDACTION is estimated to generate a significant positive economic benefit over and above the value to patients and their families of improvements in their CVD health outcomes. And I'm going to hand over to my colleague Jack, who I hope is going to share his screen. He's going to give you a little bit of a demo of the model that we've built that will allow you as ICBs, or allow those of you on the call who are ICBs, to actually have a look at what this might mean for you. Over to you, Jack.
Right. Thanks, Jackie. So first off, I'm just showing the area of the Interaction Health website that has all the impact report information. And as you'll see here, there's one called View the Full Impact Model. So I've already opened this up. And what you can do here is you're presented with the first screen and lots of information telling you about what the tool is, what it includes, and what the scenarios are that Jackie was explaining as well from Step Change Advanced. And in this version, we also have the sort of theoretical 100% optimization, just so that one can see what the absolute upper end of the predictions would be. Then you can choose your own integrated care board and the scenario you want to look at. So here we have them starting off with England. You can see those results that Jackie just explained, but you can also see every ICB in the country. So I will choose my one, which is North East London Integrated Care Board. I'll keep it at the step change scenario for now, but if I did want to change it, I can just click on the box and get the right thing up. Now, all my results are available in these links here. So first off, we get some very clear headline results from the tool. So after 3 and 5 years in North East London, the tool's expecting that, you know, we'd just under 2,000 events after 3 years. After 5 years, just under 3,000 events, with that cost to the healthcare system. But then we're expecting these benefits back after those years, and there's our cost benefit ratio between the two. And then after 5 years, that's our chart that explains those results to us. We then also have the ability to download this information. If I go up to File and I go to Export, I can download as PDF, and this information then something I can email around and share, etc. These are the instructions shown here as well. Okay. Next one, we can get a lot more detail on that information after 3 years. So again, I look at the different cohorts that Jackie explained. What are the costs? What are the efficiencies gained from that? What are the events prevented, etc. And we get a lot more detail. Same again after 5 years. Same information again, but now after 5 years. As you know that 3 and 5 years are often the sort of horizons that the planning needs to be done to. And we also have a lot of detail. So as Jackie explained, we did the modelling after up to 15 years. So here we have the overall, what's been prevented, what the cost of CVD action and the transformation cost is. I saw that was one of the questions about whether we included costs about the system change that's needed to get the extra patients in. So yes, that is included. What we see is the value by the different areas of economic category, and value by the type of events, etc., and what the cost-benefit ratio is, etc. So you get some more information about the scenarios that we've been working on as well. Jackie gave an overview, but the tool has it in more detail. And there is also some method notes as well. Some cool, good information about the method that's been used as well in the tool. You'll also see on the CVD Action Impact Model website, as part of Interaction Health, something called Download ICB Headline Reports. So here you can find each ICB and find your one, and up will come a interesting report. I'll click on Bath. So this takes from the tool, but it's a more sort of PDF version with a headline box, and then the information that comes from the tool as well, all in one place for you. Okay, so that's the overview of the tool. Hopefully that helps everyone understand what it is and how they can use it for themselves. We've really thought about what you might need for any business cases or any sort of work internally at your organisation to think about the role of CVD action. I will pass back now for Q&A.
Thank you very much, Jack and Jax, for that. Really good, comprehensive. And again, apologies for my lack of camera picture. What we felt when we saw these results is, my goodness, just how striking is this impact. So across these 4 high impact treatments, if we achieve step change, the lowest step change scenario, the lowest improvement scenario, where, for example, 80% of people with hypertension are treated to target, every year we'll prevent 20,000 cardiovascular events, heart attack, stroke, heart failure, end-stage kidney disease, generating £800 million, releasing 160,000 bed days in a year. And over 3 years, with £4 back on every £1 spent, and ICBs breaking even in a year. I cannot think of interventions or population health interventions that would have such an impact, but this is our day job. This is the stuff we're currently doing. The return on investment, some of the questions were on what costs were included, but this includes accounting for 3 costs. So the increase in drug costs, the license fee for CVD action, but really critically, 25 pence per head of population for that transformation support, which is one of the second pillar of the CVD action model. Transformation support to work with teams to change their ways of working to optimize at scale. So looking at some of the questions, yes, that is ambitious, but we need to be ambitious, but the only way we'll get there is by working differently. So this is a huge impact in a short time frame and will go a long way to delivering the national mission. But critically, it will only happen if we routinely look for and optimize the large number of patients who are not on the right treatment. So this systematic case finding is the single critical intervention that we need to make to deliver step change in secondary prevention. And hopefully we have the MSF coming, and hopefully we can use the opportunity to establish this change in practice as an essential standard in primary care. So we've got a little time left for some questions, and there are some in two places. There's some in the attendee chat, which I'll run through first. For Seema Patel, how did you calculate the costs to healthcare system? And I've just addressed that a little bit. Jack, do you want to say something about the drug costs and other things that were included in there?
Yeah, we sourced the drug costs from the national formulary, so we were able to use the latest published drug costs. It is actually quite important because I think for one of the drugs, the price, there was a negotiation that reduced the price subsequently, so we probably overestimated the drug costs for one of the conditions, but we sourced those from there. But in terms of the impact, so for example, the cost to the NHS of an event like a stroke, we sourced those from cost of illness studies, where they had already done a detailed deep dive into the costs, NHS costs of delivering services to somebody who had, say, had a stroke or a heart attack. So that's where we sourced those data from. So we didn't sort of do a bottom-up costing in that context.
Jack. And then a question from Ed. Well, it's taken a very long time to get RAS prescribing up to suboptimal level in CKD. So I do worry about that precedent. And absolutely, that is the precedent we've had for decades that we've accepted as just as it is. This is the intractable problem. And Ed says that, but that's why this approach is so needed. I think it would be interesting for ICBs to know where the break-even point is. And I know we have data on that, Jack, in the modelling.
Sorry, I didn't hear the question. Was it where modelling where's the break even for the?
Yes. So after how many years does the ICB break even?
In
I think it is in it's produced for each ICB, isn't it?
Yeah, overall for England, we're saying about a year for the health costs, for the health side of things, that you get a break even.
Yes, and that's what looking at individual ICBs, that seems to be the norm, that within 1 year of achieving step change, that you will break even just from an NHS perspective, forgetting the wider economic and social care benefits, just from the health economy, drug spend on the transformation, you will break even within 1 year. So that short time frame, that's the prevention shift that is today, not in a few years. So that should be very useful for ICBs. What else do we have? Yes, we're very happy to share the slides and recording. Nick Bird, I really like this work. Do you have financial benefit data excluding increased economic activity? So increased economic activity isn't money NHS, DHSE will realise or ICBs can reinvest. So yeah, Jack, we talked about that about half of the financial savings was was NHS and social care, wasn't it?
Yeah, I mean, it's we looked at it from a whole society perspective. So we were looking across the whole economy, and you know, that means that there are benefits outside the NHS for people who are able to get back to work or take less time off work, or in fact reduce their caring responsibilities and continue to participate in other ways that are economically valuable for the country. The reason we've presented the results separately by stakeholder is so that you can see the difference between those different perspectives. But we did want to take a whole of society perspective. just important to note that one of the things we didn't look at is the fiscal impact of this in terms of if people are working, is there a fiscal impact in terms of increased tax revenues and so on? And it is increasingly the case that the Office of Budget Responsibility and the Treasury are looking at these kinds of things, the wider social impact, the wider economic impact and the wider fiscal impact when they're looking at the value of investing in health. So really important for us to have looked at that, but and to include the wider societal perspective. But yeah, we've presented it separately so that, you know, each stakeholder can look at it from their own perspective. I did want to add something on the break even, because I think somebody put something in the chat that what would the optimization level need to be to break even? So, you know, there is some combination of percentage coverage across each of the 12 conditions that would produce a positive return on investment. We haven't done that analysis. We haven't looked at, you know, is it the step change scenario that we've modelled? We haven't looked at what, you know, whether if you can get 80% there, whether that takes you to your break even. But it would be an interesting thing to think through.
Thank you, Jax. Then we have a question from Ben. As a system, we are good on what to do, as you note, with clear, nice guidance. We're poor at delivery of those interventions across the population. There are those we know about who are not being well managed, but a bigger issue is those undiagnosed and not aware. How do we get better engage these population segments beyond the known diagnosed patients you looked at? It is such an interesting point, isn't it? I'm not sure if it's a bigger issue. I just think they're two huge issues, and we absolutely have to be addressing both. There are a lot of patients with undiagnosed high-risk conditions, like Annika I mentioned at the beginning. But even when we diagnose, we find new patients from a community activity around blood pressure measurement or through the NHS health check. Still, a third of those will not be treated to target. So these are two big issues. I think there is certainly learning around how we could do things much better at supporting case finding for people who are undiagnosed. We have a lot of activity, and we got very excited about activity, some really creative stuff working in community settings, for example, to find patients with hypertension. But I know that I think there's quite a lot of evidence that often doesn't lead very far, that patients then struggle, we struggle to get data transfer into primary care, or patients struggle to connect and get appointments and get follow-up. I think there's a lot of learning about that. So looking critically at how we provide those interventions with a much bigger focus on activation and different pathways, different ways of offering services in communities. It's not enough to have the case finding activity. In CVD Action, we have built a case finding element for a number of the conditions. So we'll find patients on our books who are not coded, have not been picked up, but may well have the condition. And I think there was a question there on health inequalities, which I'll try and find. Yeah, Bryn, have you stratified your results by deprivation status? Do you see larger health gains and greatest financial ROI in the more deprived areas? And Jax may want to talk to that, but we didn't include analysis on that. But within CVD Action, we have built this in as a very pragmatic tool that for all the indicators, all the cohorts who you identify as being not on NICE recommended treatment, you can stratify by age, gender, ethnicity, deprivation, severe mental illness and learning disability. So in a practice, you could find all your patients with, say, severe mental illness who, as we know, die 10 to 20 years early, and they don't die of severe mental illness on the whole, they die of heart attack and stroke, etc. So you could find all those patients in your practice, or you could do it at bigger scale across your PCN. But because CVD Action will give you system level view across a population, you could identify all of those patients across a neighbourhood or an ICB, so that you're not just sending them an appointment in the hope they'll turn up, but actually putting in place wider support to activate and support those patients with community-based services, etc. So, Jax, I don't know if we did talk a lot about how to bring health inequalities into the analysis. don't know if you're still there, Jack. Jax.
Jack's on mute.
Sorry, I was on mute. Somebody had to do it. Yeah, we didn't look at subgroup analysis at all. The data that we had didn't really allow us to do estimates of effect sizes and cost of illness for individual subgroups. And just on a more general level, I mean, I think we are being hugely encouraged now to produce economic analysis for different socioeconomic groups, so as to demonstrate differential impacts for people with health inequalities. But we're not very good at differentially valuing that, you know, so assigning an equity weight, if you like, or a higher value to helping somebody who otherwise has shorter life expectancy. There's not a lot of universal agreement about how to do that. So we tend to just focus on trying to produce results by different socioeconomic groups. We haven't done that for this study, but as you said, Matt, you know, the local data is available to actually look at where the where people are not being medicated optimally by socioeconomic groups. So you can really focus and target on those individuals in terms of how you prioritise locally where you want to put your efforts. We would always encourage to focus on addressing health inequalities.
Yes, definitely. I mean, the central objective with this work was to measure what would be the impact if you do this at scale. And so to do that, we deliberately didn't try to answer every question or build the most complex model that covered all bases, but just to answer that core question with 4 high impact treatments that are all NICE recommended but underused, because it answers the sort of principal question of what difference does it make in the answer? Well, it's huge. But then we can move beyond that to say, well, if in my ICB, I know if we optimize these treatments, even just to step change level, the impacts on my population and the economy will be huge. Within that, I also know that CVD cardiovascular disease is a major driver of health inequalities, accounting for a fifth of the life expectancy gap between rich and poor. So if I know that, and I know the impact I can have, because CVDACTION will find all those patients in deprivation quintile or an ethnic group, I can, by targeting my resources on those patients, on those communities, I know that I will have a differential impact on health inequality. So it very much allows that approach. Another question from Ben on QOF. What changes do you feel are necessary in current incentive programs to enable achievement of the target coverage? The current business rules would need to be changed significantly to get those outcome levels. Yes, I mean, QOF has been under review for a while and it's still under review. And I imagine that how it changes will be influenced by the modern service framework when it's published. It is despite QOF that we've had pretty well static picture for a long time, the two or three decades that QOF has been in place. So in UCL Partners, we develop size of the prize that's updated every 3 months to show how many people with hypertension are treated to target, and we draw on the CVD Prevent data for that. And what that shows really interesting, if you Google UCL Partners size of the prize, you'll see the picture there. There's a really striking picture in the bottom left corner every 3 months, and it shows that we've had slow progression in recent years so that we've still not got back to the pre-COVID levels. But it also shows you that our performance in general practice peaks on the 31st of March every year. And we all get dead excited about it around the country that there has been that substantive improvement. But then if you look at June, it goes back to baseline on the whole. There may be a slight upward movement. And it's because, we're so busy in primary care. We do it all to meet the QOF targets, and then we move on to other priorities, quite rightly, you would say. I guess our thinking about incentives is that perhaps we need a sort of twofold approach here. One is we want to support primary care to work differently, so to make it routine to look for and optimize people who are not on optimal treatment. and we need to change our pathways to do that. So I think some QOF or national incentive could be to help us resource that change. And we've built that into the modelling. That costing was in there at 25p per head of population. And the CVDACTION model, we provide that support. But so one element could be to resource primary care to make that change. Because if we don't make the change, we won't deliver this sustainably for the future. But I think the second element could absolutely be a financial incentive for reaching a target. But I guess our learning over a number of years on this is that what would make a change is that for that to be a step change target. So not enough to have an incremental improvement from 67 to 72%, but actually to 80% or 85%, so that we get some resourcing to work differently, and then we get a significant resource if we achieve step change in improvement. So I'm sure there will be lots of other ideas out there, but I think that's one way in which incentives could align with this broader approach. Just trying to see if there are any other questions there. Josh, out of interest, why did you not include lifestyle and behaviour interventions? And Jack, you may want to comment on this from a sort of methodological perspective, but I guess lifestyle and behaviour change is critical and is the starting point, and we must absolutely be doing that. But the focus here was to focus on what's now called secondary prevention. And again, my experience from my NCD days was that I think historically in general practice, we've had to use this as a bit of a fig leaf. We acknowledge that prevention is very important, but actually prevention's the wider stuff. It's lifestyle, it's political change, etc., which is all true. But we've wanted to move away from that fig leaf and confront us in primary care with the hard facts of where the improvement is needed, in a supportive and enabling way. But so from that perspective, didn't want to cloud this with the wider analysis around lifestyle and behaviour change, although we know it's important. Jax, did you have anything to say on that?
Yeah, I mean, it's not that we've said nobody in the model will have had lifestyle and behaviour change interventions. The estimates that we've used to look at the impact of medications, insofar as they're experimental studies and well-done studies, there will have been an underlying engagement by the participants in those studies in lifestyle change interventions. So what those studies have done is to try and isolate the marginal extra impact of medicines optimization. And that's what we've used to focus our analysis. So as you say, Matt, it's really been focused on that rather than all of the other things that you could otherwise do, all the other determinants, if you like.
Yes, definitely. Thank you, Jack. And Jack Tepkady, a question just come in. I see it's welcome to see an approach that looks across all or several CVD risk factors rather than individual risk factors. Is there a way we could model impact of routinely including care, behaviour change interventions, not just medicines? And also for medicines, look at weight loss medication as well. On the latter point, in version 2, we're building in obesity, so that would include the GLP-1s and related drugs. I think that broader question is such a good question, and I don't know if we need to model that at this stage. What we've done is build a model that shows if you work differently by identifying patients, stratifying so you can safely prioritise, break them up to small numbers so you can fit it into workflow and capacity, and then optimise their medical care, then you get a big impact. But I think the principle here is that if you change ways of working in this way, in our work with PCNs, helping them to change ways of working, that brings in the wider, more holistic care. So managing multiple risk factors at the same time, both the medical and non-medical. By changing your ways of working and addressing multiple risk factors, you then get the headspace to address behaviour change. It's another thing we're not very good at in primary care at all. And it's partly because of the way our work's structured in lack of capacity. And it's always the thing that appears at the end. So I think changing our ways of working gives us the opportunity to provide better proactive care across a whole range of factors, not just medical, not just behaviour change, but also support for wider social determinants of people's health behaviour and access to services. Let's see. Can the data be drilled to PCN level? No, we've not built that in to the model. I think the numbers get quite a bit smaller when you get down to PCN level, so it may be a bit harder to interpret. But again, I'm not sure if we need that because the numbers are so huge. I mean, Jack, again, you may have a view on this, but because the impacted cost numbers are so huge, I think you can quite reasonably apply this to a sort of subpopulation just on a proportionate basis. Is that reasonable, Jax?
Yeah, I mean, I think it probably is. I mean, I think it's each individual PCN, the impact would be different given the local context. We haven't, for example, weighted the numbers to reflect higher costs in London. So, you know, there are lots of sort of local contextual issues that would probably impact not just the size of the population, but the geography. But these results are quite compelling, and the answer to the exam question, is this likely to generate value for money for the health system over this period of time, if adopted across an ICB, I would have said that exam question's been answered well. So, you know, looking at it at individual PCNs, yes, each PCN is going to have a similar kind of trajectory, I would think, depending on where they're starting from.
Thank you, Jax. Maybe the last question, but Sanjeev, since the national return benefit is so great, are there any plans nationally to invest in drop-in teams resources rather than rely on local action? Certainly what we saw in the demonstrator programme was that some areas, for example, in big neighbourhoods or federations, offered a hub approach to take the data and optimise at scale. So I'm sure that you will see that sort of scaling approach. Very conscious of the time, 13:29 in the last minute. I'd just like to thank you all very much and remind you in 3 weeks' time, we will be going into much more detail about CVDACTION, how it works, what the offer is around the smart data, but also that structured support for transformation and structured support for delivering step change objectives. So look out for that. We will email everyone who's been on the call today with information, and please do pass on to others. So thanks very much for our presenters today and the team, and really do hope that you found that helpful. Okay, goodbye.